Our pleasure to have my colleague Sonikpreet Aulakh here from WVU as well, our esteemed boss in neuro-oncology here. So we're gonna split our time here, and what I wanted to talk about today is, no disclosures. So what we're gonna talk about today is acoustics, vestibular schwannomas. Here we are, this is Morgantown. Tiny small town here in the north corner of West Virginia, about an hour and a half south of Pittsburgh. Here's our main campus, about 30,000 students or so every year on the main campus set along the Monongahela River. This is our Rockefeller Neuroscience Institute, led by Dr. Ali Rezai, our Center of Innovation and Research. This is one of my favorite photos because this is when all of West Virginia comes to support the American football college team, the WVU Mountaineers. And in the back, this is our hospital. And this is the main parking for our hospital right here. So everybody floods the hospital, the poor patients and their families. I don't know exactly where they park. Even the faculty who are on call have to find some place to sneak in and park. So the whole town comes out, turns this sleepy college town into a booming number of hours on Saturday afternoons. So what I really wanted to focus on today was hearing preservation. For so long, any study looking at acoustic and surgery or radiosurgery is focused on facial nerve outcomes, and rightfully so. But what we have more been focusing on with SRS and subtotal resections has become hearing outcomes and quality of life for these patients. And I have a tough case, or at least a tough case for us, of an NF2 patient that I wanted to show you guys, and really then turn it over to Dr. Aulakh and see how medical management has come and progressed to help us in these challenging situations. So here's our patient, DS. This is a 28-year-old guy who newly diagnosed with NF2 in September of 2018. This was 2 years before my time coming here. So he came in, one of my partners saw him, and I'll just scroll through this: bilateral large, acoustics, vestibulars, involvement of the jugular foramen, expanded IACs bilaterally. There's the measurements there. Significant brainstem compression. You can see some temporal horns there. He's got some evidence of obstructive hydrocephalus. So here is his flare at that time, and the rest of the brain just showing some transependymal flow. Even though there's a lot of brainstem compression, not a lot of flare or edema into the stem. So 28, newly diagnosed, he gets admitted, gets worked up. He's found to have bilateral papilledema. You can see his hearing profile there, his audiogram. So one of my partners puts a shunt in, sends him off with some plan to follow up somewhere else. But as in many of our patients in West Virginia, access to healthcare is an issue. So somehow he gets treated with Avastin by a local oncologist, but ultimately has to stop because he can't make the payments. So this is one of my first clinic patients when we started here. This was back in July of 20. So this is how things had progressed. Significant growth of the right vestibular schwannoma, more brainstem compression, maybe even some heel invasion at that point. And his flare at that time, this is what every lateral skull-based surgeon dreads to see. When we were dealing already with the large tumors, significant edema around the fourth into the middle cerebellar peduncle, and really all the way back into the back of the pons there. The shunt is working well though, so that's the good news. There's his audiogram at the time. He's functionally deaf now. So running through sporadic vestibular schwannomas, observation is always our first option. This is the largest study that I could find regarding the natural history of vestibular schwannoma growth. So this is a study out of Copenhagen, Denmark, and looking at their 40-year data. 3,600 patients that they captured from those dates, and their follow-up plan was to obtain a yearly MRI for 5 years, and then with subsequent decreasing frequency as long as there was stability. They divided them into intrameatal, intracanalicular tumors versus extrameatal with a combination of intra and extrameatal components. Initially, 1,200 plus patients underwent surgery. That left 2,000 plus for observation. They ended up during the period of follow-up at losing about 20% more of those patients who had significant brainstem compression and underwent surgery. So for the growth data available for these patients, 81% of the patients with intracanalicular tumors were observed. At 10 years, 25% had grown. And ultimately, at the end of their study, 56% of these were still managed conservatively. And the extrameatal, you can see there, 88% of the patients had growth data for their tumor. Significantly more had grown at 42%. Still at the end of their study, 38% were managed conservatively. Ultimately, what was seen in their study is that after diagnosis, most of these tumors stopped growing significantly after 5 years and after 10 years of observation for the intracanalicular tumors and the extrameatal tumors. About the 10 to 12 year period is when they observed that most of these tumors stopped growing. No hearing outcomes on these on this observational trial, retrospective trial. And here we can see no treatment, meaning just conservative options for 88% of the intrameatal tumors, 71% of the extrameatal tumors. So this is a study from Ohio State, a small study, but still important. Again, looking at what happens to hearing when we watch these tumors conservatively. So 21 patients, 6 with NF2, follow-up for at least 2 years. Over that period of time, 14 patients had a 10% change in tumor volume. And classically, this is where we think tumor's going to grow, hearing's going to get worse. So this is the AOHNS hearing grades, class A, B. They didn't have any in C, class D. So A and B, serviceable hearing. And what they saw over time in the class A, despite some changes in significant volume, class A still remains very good. Speech to scrim still remains very high. As tumor volume grows in class B, we see hearing outcomes get worse. And patients who start with bad hearing, well, their hearing just gets worse as the tumor grows. So even though there was a variable growth of tumors, patients generally who had poor hearing and growth of tumors had a significant more decline in their hearing than class A or B. And their thought was that their reserve was depleted, whether that was from vascular or neural compression. This is a good study from Mayo, Dr. Link, Dr. Carlson, again, looking at hearing outcomes. So over 14 years, they had 213 patients with serviceable hearing, class A or class B. You can see most of them were class A. Larger tumor volume at diagnosis correlated with worse pure tone audio and word recognition score, just similar to what we saw from the Ohio State study. You can see their tumor volume is pretty small on median. So 99 patients experienced volumetric growth, 23 developed non-serviceable hearing with a median of 1.8 years following growth. But what was interesting is the tumors that were growing didn't really make a statistical difference to the non-serviceable hearing outcomes from non-growing tumors. So the volume of growth really didn't change how bad that hearing became. Non-growing tumors had worse hearing outcomes too, or bad hearing outcomes as well. Well, what about Gamma Knife? What's the role for Gamma Knife? Dr. Lunsford from Pittsburgh here just up the road, strong advocate for early Gamma Knife. He put together his series of 120 patients, COOS grade 1, unilateral intracanalicular tumor, serviceable hearing, and subsequent audiometric follow-up from 87 to 2017 with a mean follow-up of 41 months. So here's what he found. All comers, you can see the gradual decline over 120 months of hearing. Now we're at about 40%, a little under 40% of serviceable hearing. What he found significant in his study was that patients greater than 55 tended to have worse hearing outcomes than those under 55. Good hearing patients tended to have better hearing than the grade 2 hearing patients. And tumor volume was also a significant risk factor for preservation of hearing. So he recommended early SRS. His thought was that these growing tumors, he suspected volume growth did affect hearing preservation based on their initial period of observation there, and was able to map out about 2.9 millimeters per year per growth. Did not have the benefit of having as long follow-up as the Denmark study, so it's hard to know what would have changed over time, but his aim was to show at least equipoise with gamma knife radiosurgery for natural history of watching these tumors from a hearing outcome standpoint. So here we are with hearing preservation. These are our approaches. Translab is out, obviously. Hearing is sacrificed as the labyrinth is taken down and the vestibule is opened. And so we're left with retrosigmoid approach, which all of our esteemed panelists know well, and the middle cranial fossa approach. The pros and cons to each you all know well. So this is a study from Dr. Cohen-Gadol, who's in Indiana. 5,000 patients through PubMed search were identified in a systematic review. So comparing hearing loss in our middle fossa and our retrosigmoid approaches, tumors less than 1.5 centimeters. So hearing loss, 43% for patients with small tumors and intracanalicular, tumors less than 1.5%. From the middle fossa approach, 64% from the retrosigmoid approach. As tumor volume goes up, middle fossa not so good, 82%. Still pretty good in retrosigmoid. And as tumor volume gets above 3 centimeters, middle fossa has probably no role. As advertised, they didn't have the data for that. And still relative preservation of tumors, relative preservation options of hearing for tumors greater than 3 centimeters. So this is the view through the middle fossa as shown by the Jackler Atlas from Stanford. This is what you get. This is a tough, long, deep approach for those of us who've done it. That's the facial nerve being dissected there. Probably an inferior vestibular tumor in origin, the microdebulking peeling away from the cochlear nerve, and that's what you're left with at the end. So Cohen-Gadol suggestion, middle fossa approach for tumors less than 1.5 centimeter extension into the CPA seem to have the best hearing outcomes. In tumors 1.5 to 3 centimeters, retrosigmoid may provide better rates of hearing preservation. This is Dr. Yang's review, UCLA, systematic review of patients, 2,000 plus patients undergoing retrosigmoid craniotomy and how their hearing outcome. So 944 patients ultimately ended up being reviewed in the series, and you can see there who underwent it. Most of them were large, greater, as they define greater than 20 millimeters, 2 centimeters. And the relative hearing preservation, better to have small, obviously intracanalicular tumors, and then as the tumor gets larger, percentage of preservation of hearing decreases. So what are our guidelines? What do we know? This is a 2018 neurosurgery article from, again, Dr. Carlson at Mayo, who tried to summarize what our best available evidence is and how do we counsel patients. So regarding serviceable hearing for observation, 2, 5, 10-year timestamp, pretty good that it's going to be good at the 2-year, and moderately high that you'll have some hearing preservation, and moderately low at 10 years, so conservative. Very similar to our guidelines for gamma knife, the same, really equipoise in terms of the recommendation. All level 3 recommendations have, albeit. And here we go for surgery. All comers, small to medium size. Well, you know, the guidelines level 3, again, probably we're going to make that hearing year worse initially and over the 2-year and 5-year standpoint. But with good hearing, small tumors, really similar guidelines as what could come from observation or gamma knife radiosurgery. And just to talk a little bit about ABI, this is something for our challenging patients with NF2. This is improved in NF2. This looks just like a cochlear implant with the electrode array instead of having something inserted into the cochlea. This is the electrode array that sits on the cochlear nucleus that's inserted in the foramen of Belushka on the dorsal and ventral cochlear nucleus. So this is a Schwartz sketch, who's now at San Diego, was a longtime house lateral skull-based surgeon, famous acoustic surgeon. This is just the intraoperative view with 7. And again, here's the lowers with flocculus and the insertion of the electrode into Luschka. Monitor this at the time of the surgery to make sure everything's making good contact. So the whole idea is really sound awareness. This is a study from the US clinical trials in 2000 looking at what is gained. It's not as good as a cochlear implant, but still up to 10% of patients with open set word recognition, which is huge. When that happens, only seeing, even though 81% of patients do receive auditory sensation, still about 20% of patients don't benefit at all. Lip reading is enhanced, and 93% of patients at 3 to 6 months do demonstrate improved sentence understanding. So back to our patient. Here we are left with our challenge here. So we had slowly planned to get him to the operating room. He actually came back to the emergency room with just profound brainstem compression symptomatology, was unable to stand, was nauseous, vomiting. So everything advanced more slowly. We elected for a retrosigmoid resection. This is after our first case. Here's his MRI. It's our practice here to leave anything stuck to the brainstem behind. This is really in what I've seen by my own eyes and by the literature. If you really start rolling that tumor from medial to lateral and you see that brainstem come up with you, you best leave that behind. Otherwise, you're going to wake up with profound deficits. And so there's his first result. He had a rocky course, ended up getting trach and PEG aspirating after his initial surgery, some lower cranial nerve dysfunction or potential nuclear dysfunction. Ultimately made a good recovery. We gave him a number of months to come back to recover. And here's his MRI 6 months later on the clinic follow-up. And at that time, we noted that the left tumor had started growing. So here we are back to stage 1. Here's what that was interpreted as some consolidation of the tumor on the right and subsequently followed. It has been stable. So then he was independent, ambulating and feeding himself, and ready to sign him up for round 2 of morbidity. So we performed a left retrosigmoid at that time. And here we are just a couple weeks ago. This was in his follow-up with Dr. Aulakh. And so this is what he is left with. Still residual tumor, but from a functional standpoint, he is ambulatory, he's independent for the most part, still some persistent diplopia. House Brackman, his face is working, grade 1 bilaterally, and right now his current treatment is just Selumetinib, so no adjuvant SRS yet, and we're still seeing tumor stability about 1.5 years out. This is Cooper's Rock, one of our famous scenic landmarks here in Morgantown. So I think I'll turn it over to Sonik now to tell us the rest of the story.
Thank you. I think, Jeremy, you'll have to scroll it.
Sure, just, yeah, let me know when.
Okay, so thank you so much. I saw this patient, I think 2 weeks ago, drastic improvement from where we began until now. And he does have NF2 somatic mutation. We did ask for genetic counselor and see if he has germline NF2 mutation. So basically, anytime you have NF2 related vestibular schwannomas, the reason these vestibular schwannomas happen is because there is an inactivation of NF2 tumor suppressor gene. And now that inactivation can happen either by 22q chromosome deletion or by mutation. There can be biallelic hits or there can be one hit. They are 50-50, so 45% biallelic hits, 41% just single hits. And what happens is in the auditory canal, in the meatus, the vestibular nerve gets multiple hits, clonal evolution, and then double hits. And that is why the recurrence rate is higher and the surgery is difficult to remove all the tumor arising of that vestibular nerve. Now, in terms of how do we manage that medically, obviously there are no consensus guidelines that how to manage them medically. And one of the hurdles is there are also non-NF2 related vestibular schwannomas. Now, morphologically, phenotypically, they look alike. They have loss of Merlin or absence of Merlin in the tumor bulk itself. And the reason these are absent, one would hypothesize that it could probably be just due to NF2 loss, but there are actually certain other chromosomal remodeling aberrations such as ARID1A, ARID1B, and a plethora of those mutations to a lesser extent, but those also lead to loss of Merlin. But also there are certain non-NF2 related epigenetic alterations leading to the complex biology of vestibular schwannomas. Next slide, please. These are NF2 features we are all aware of. And the reason we have to, especially as a neuro-oncologist, need to keep this in mind because a patient may present with unilateral VS. If it's bilateral VS, slam dunk, we make sure all of the other symptoms or all of the other signs, we follow them in the long-term screening. But sometimes when they present with unilateral VS and they did not have any development of meningioma, glioma, or neurofibroma, in those cases, diagnosis becomes very difficult. And these are the cases where I personally and some of my other colleagues in the vestibular schwannoma world from the oncology side make sure that we send the whole exome sequencing. And if not whole exome sequencing, we have limited 800 gene panel, which does capture that NF2 related somatic mutation. Next slide, please. And when to consider NF2, both somatic and germline, if their age of presentation is less than 30 years, there are certain germline pathogenic variants which happen in 10% or up to 10% of patients. An older individual who have two NF2 related features. So our patient, when he initially was presenting with NF2 related VS symptoms was 28 years, and that raised our suspicion of pursuing further studies. Next slide, please. As I said, this is a complex biology, and even though we have, all these newer diagnostic modalities in terms of histopathological diagnosis, we do not know and fully understand how does it relate to the prognostication or guiding therapy, but that is changing. And ENO, European Association of Neuro-oncology, have certain guidelines. And as Dr. Lewis was initially mentioning, that observation, surgery, radiation, and followed by medical management. But when we differentiate them at the molecular level, we have to also consider melanotic schwannomas, melanocytomas, and cutaneous melanomas, because how they present, these can only be differentiated based on these hotspot mutations, which I have mentioned here. Next slide, please. Again, local therapies are the mainstay of treatment. There is no level 1 evidence for any systemic therapy. We do level 2 evidence to select certain patients who will benefit from the precision medicine, personalized medicine, where we have genotype targeted therapy based on understanding of the tumor itself, as well as the tumor microenvironment. Obviously, we have not been able to expand the single cell RNA sequencing or whole exome sequencing for that matter in all patients, but we do have 800 gene panel that we can apply to these patients and have some viable information to guide our medical management. Next slide, please. So Avastin, or Bevacizumab, Avastin is the generic name. It's a VEGF monoclonal antibody. And this was the trial which was conducted where they had 14 patients with NF2. And the primary objective of the study was to see what would be the impact on the hearing loss, as well as the objective response. And they used 7.5 mg per kg. It's an intravenous infusion every 3 weeks. And fairly tolerable. We have to be cognizant of the patients who have a history of venous thromboembolism, because it can definitely affect that. Patients who have hypertension, they do not exclude those patients from receiving Avastin, but we always have to be cognizant in making sure that they have either a cough monitor at home. And if they go above certain limit, we can start them on antihypertensives. But it's very well tolerated, because I use this for my glioblastoma patients. And other than the complication of bleeding or clotting, I've not seen any major adverse events. Next slide, please. So this was actually one of the only study which met the primary endpoint. And as you can see here, the word recognition score after Avastin treatment, as well as the baseline volume after Avastin treatment, and baseline volume meaning the residual tumor volume was reduced. So it met the criteria, and that's why Avastin is one of the hot drugs we use in NF2 related either unilateral or bilateral vestibular schwannomas, mostly in the recurrent setting, or after local therapies if we think there is enhanced growth kinetics on the MRI of the brain, as we take care of them every 3rd to 4th month. We usually try to obtain it in first 2 years of their diagnosis. Next slide, please. Erlotinib, it's an EGFR inhibitor. It's an oral drug. It's actually used in lung cancer. And because of the mechanism of how NF2 downregulates the or EGFR, they tried using this in very few number of patients, but unfortunately did not meet the criteria of showing any objective response to this oral kinase inhibitor. Next. Everolimus, we're very familiar with Everolimus. It's used in breast cancer. It inhibits mTOR. And this is a waterfall plot. It just had 12 patients. And as you can see, when they were assessing the tumor volume, and they also used the tumor volume as a whole, but it did not lead to any reduction in the size of recurrent VS. Next one. Again, this is the Kaplan-Meier showing the progression-free survival probability. And unfortunately, it did not lead to any significant difference in overall progression-free survival of patients who received it versus who did not receive it. Next slide. Selumetinib, which Dr. Lewis mentioned for our patient, actually is currently being tested in an ongoing phase 2 study where you use Selumetinib. It's again a MEK1, MEK2 inhibitor. It was approved by FDA in 2020 for patients with NF1 related inoperable and symptomatic plexiform neurofibromas. And because we are advancing towards personalized medicine, we were able to make a case for using Selumetinib for our patient. And as you could see, the MRI after surgery, and patient, as Dr. Lewis was mentioning, has not received any gamma knife radiation surgery. In fact, we discussed this patient in the tumor board this past Friday, that we feel that we will just continue the systemic course with Selumetinib. This is again an oral drug. It is very well tolerated. It does cause grade 1 through 4 acneiform rash, but they're very manageable. You can use some oral steroids, topical steroids, oral antibiotic, and Accutane as well. And the goals of this study, which is currently accruing patients, is to determine if there will be any effect of using Selumetinib on this tumor, measure any changes in hearing, which is again our endpoint, because this is again a quality of life issue, and determine if Selumetinib improves how patients physically and emotionally feel. So I can share the experience of this patient. He does have grade 1 acneiform rash. For that, basically, we continue the same dose. He did not show any increase in CPK, because that's one of the lab number which we check every 2 weeks for first 2 months, and then every month. And if it is grade 3 or 4, either you have to interrupt the treatment or stop the treatment if it's grade 4, or change the dosage. Again, because we do know that this penetrates the nerves and also has BBB penetration. So this is actually a viable option for these patients who probably have either failed Avastin, and as Dr. Lewis was mentioning, because of these patients have lack of insurance, or for some other adverse event which precludes us from using Avastin, we can proceed with Selumetinib. But again, this is still going on in a trial. So these are the options which we can use. But beyond that, I think one of the key to manage NF2 related vestibular schwannomas is look at the genetic profile, which I think is very, very important. Sometimes they have these epigenetic alterations which could be associated with NF2, and these epigenetic alterations with their advancement in understanding on other brain tumors, you will actually be able to use off-label targeted therapy for the same. So with that, I finish the medical management side of things. I thank you all for, and we'll be open to discussion.